This is a video which demonstrates the approach, technical aspects, and decision-making during a venous thrombectomy for acute on chronic thrombus in a patient with an IVC filter. There will be a separate and likely much shorter video to discuss the patient's overall case. This video presumes a baseline level of medical knowledge and familiarity with the modern tools used to treat DVTs. Very briefly, this is a 74-year-old man who presented to us with severe disabling abdominal, scrotal, and bilateral lower extremity edema. An IVC filter had been placed 3 months prior for pulmonary emboli and an inability to tolerate anticoagulation at the time. The patient endorsed symptom onset a month prior to presentation. The patient was able to be fully anticoagulated 3 weeks prior to presentation. A duplex revealed extensive thrombus throughout the bilateral lower extremities. Given the severe symptoms, the decision was made to perform venography and possibly venous thrombectomy. Technical considerations for this were the presence of an IVC filter and likely chronic thrombus that we were going to encounter. Given the abdominal and scrotal edema, I had suspected that the IVC filter was involved in the DVT. I elected to start with the patient in the prone position and access both popliteal veins based on the extent of the thrombus in the legs based on the ultrasound. An argument can be made for placing a right internal jugular vein access, and we left this as a possibility for later in the case. We start with venograms from our popliteal access points. Here you can see contrast very slowly moving into the pelvis from our lower extremities, and you can see numerous cross-pelvic collaterals that are filling with contrast slowly. After this, we then advance our advantage wire along with a burn catheter from the left lower extremity. You can see with the aid of a loop, our wire and catheter combination rapidly enters into the inferior vena cava. We then perform a cavogram, filling contrast into the IVC, but does not easily get past the IVC filter, which is filled with thrombus, and you don't see any real reflux down into the patient's right lower extremity, but you do see some down into the left. After we obtain our cavogram, we then reinsert our wire, and this is then brought up to the IVC filter, traversing the thrombus that you see. This moves quite swiftly, and after the wire is able to get up to the IVC filter, our catheter is followed up to the filter. We really do want to get a good cavogram at the level of the filter, looking for any thrombus that might be above the filter. It is difficult to see in this picture, but there is some thrombus on the left side of the screen just above the IVC filter. After we obtain these images, we then want to get our wire out of the way and establish a rail from which we can now work from the patient's left side. Therefore, we advance our advantage wire up to the patient's right subclavian vein. This is then chased with our burn catheter, and our wire is then removed in exchange for an Amplatz wire. We then turn our attention to the patient's right lower extremity. You can see our advantage wire now trying to seek and find its path up to the inferior vena cava. It buckles, likely from chronic thrombus, in the patient's right common iliac vein. A burn catheter is then introduced, and then we try and cross the thrombus with the combination of our advantage wire and our burn catheter. This can be incredibly tedious depending on the chronicity of the thrombus. Here you can see multiple attempts to advance our wire and catheter combination without much success. It is very important when trying to cross these very chronic lesions to be rapidly seeking with the wire and catheter combination, looking for any little channel that might allow you to traverse the thrombus. Here you can see the wire buckling, but sometimes finding a small channel on the right side of the patient. Once this is found, the movements are brought much smaller, and the wire is buried into this softer portion of the thrombus. The catheter is then advanced, and now you see torqued into the thrombus to allow for a channel to be created, and the wire is then advanced into the inferior vena cava. Once the wire is in the inferior vena cava, the catheter follows quickly, and then we bring our wire up through the IVC filter and bring it into the suprarenal IVC. Once we have our wires in the inferior vena cava, we then introduce our first thrombectomy device. This is a T20 flow retriever from Inari Medical. You can see it advancing first through the femoral veins and then through the iliac veins and up into the inferior vena cava just below our filter. After this is in position, we remove our dilator and we are able to then start our thrombectomy. You can see here the T20 is moved back and forth throughout the iliac veins as well as the inferior vena cava, with aspiration thrombectomy being performed segmentally throughout these veins. The need for multiple passes in each area is necessary secondary to the chronic nature of the thrombus that is being removed. Once we are happy with the inferior vena cava, we then turn our attention to the filter itself and perform thrombectomy within the filter, slowly working our way up and down the inferior vena cava and aspirating rapidly as we move throughout the deep veins. We then perform one more thrombectomy throughout the lower inferior vena cava as well as the iliac veins. And once this is completed, repeat again in the inferior vena cava filter to try and extract as much of the chronic thrombus as possible. We then perform a venogram, which demonstrates a significant reduction in the amount of thrombus throughout the entire inferior vena cava, as well as some contrast filling the right iliac veins. Once this is complete, we then turn our attention to the patient's left leg. We hope to be able to clear the remainder of the thrombus using a clot retriever, as it is significantly more efficient at removing chronic thrombus. We therefore pass a burn catheter over our wire and then retract our wire once the burn catheter is in the inferior vena cava. The patient's right common iliac vein is then cannulated using our burn catheter and our advantage wire. You can see here the wire and catheter combination traversing the iliac vein quite easily. However, when we transition down into the femoral vein, you can see that this is a little more difficult owing to the fact that our wire would routinely catch on several valves. These, however, were easily passed by manipulating the wire with our catheter, and ultimately we were able to advance our wire into the femoral vein with the goal of then cannulating our popliteal sheath in the patient's right popliteal vein. Here you can see the wire now moving down into the popliteal vein and catheterizing the popliteal vein sheath. This is externalized, allowing for a rail to then be used for our clot retriever, which you can see being placed here through our left popliteal access and going up to the confluence of the patient's iliac veins. Once the confluence is crossed, the two portions of the clot retriever are separated, and now you can see the forward portion of the clot retriever being advanced further into the patient's iliac veins and then ultimately the patient's right femoral vein. We then slowly retract our clot retriever to clear the patient's left iliac veins and femoral vein. Here you can see it being retracted. We repeat this several times in different orientations to allow for removal of thrombus in different orientations. Once again here, you can see the clot retriever being retracted in a slightly different orientation to facilitate removal, and then its replacement back into the patient's iliac veins in order to allow for another pass. This was repeated a total of 5 times, and we made care to not drag the clot retriever over the confluence directly, allowing for it to move across the confluence without any tension so as to not have it get caught. We then perform a venogram from our left popliteal access. Here you see contrast filling the femoral and iliac veins and then washing out as more flow comes through the left lower extremity. Happy with this, we then turn our attention to the patient's right lower extremity. We access our popliteal access on the right and inject contrast. Here you see contrast filling the iliac veins and the inferior vena cava. However, you do see that there are some collaterals existing on the right side that do not exist on the left. With these in mind, we do think that there is some residual chronic thrombus in the common iliac vein, which we intend then to angioplasty. Here you see our balloon catheter being inserted via the left popliteal access. We then position it in these areas of residual thrombus and insufflate a 16 millimeter balloon, pushing the residual chronic thrombus to the side. You do see several areas of wasting on the 16 millimeter balloon, both at the confluence as well as in the patient's right common iliac vein. After this is performed, we then move our wire up into the inferior vena cava and insert our T20 flow retriever to retrieve any thrombus that we may have accidentally liberated into the filter. We also want to repeat our injection at the site of the filter in order to ensure that we have clear flow through the inferior vena cava from both of our lower extremities. Here you see us positioning our catheter directly inside of the filter and then performing our venogram. Here you see thrombus just above the filter on the left side of the patient, which we saw previously, although this is demonstrating it better. But there's brisk flow through the filter into the inferior vena cava above the filter, as well as the renal veins. We also perform a cavogram below our stent that demonstrates some reduction in the number of collaterals coming from the patient's right iliac veins. Happy with this, we then turn our attention to the patient's left iliac veins. We introduce an intravascular ultrasound and interrogate the veins from the inferior vena cava down into the left iliac and femoral veins. We look for thrombus as well as the patency of the vessels. We identified a May-Thurner lesion in the left common iliac vein that was over 90%. We therefore decided that we would stent this using an Aubrey stent. After sizing with our ultrasound, we decided to use an 18 millimeter Aubrey stent. Here you see us positioning it based on our intravascular ultrasound as well as the wire from the patient's right popliteal vein. The stent is slowly deployed in the patient's left common iliac vein. As the device is slowly retracted, the stent expands. You can see some areas of still compression, and we decided at this point that we would need to post-dilate this with a balloon. We selected a 16 millimeter balloon and introduced this into our stent. We post-dilated the stent, conforming it to the left common iliac vein. After placing our stent, we then performed our final venograms, first from our left side. This demonstrated good flow out of the left lower extremity into the inferior vena cava. I wasn't particularly happy with the positioning of our stent, as it did encroach upon the confluence more than we had intended, but there was brisk flow getting through the stent, as exemplified by the negative on this image. We then repeated our injection from the right side, and this demonstrated good flow through the stent and out of the right lower extremity. Happy with this, we concluded our procedure.